Welcome, everyone. If you're joining us today, you're likely a surgeon, an anesthesiologist, or a critical care specialist, which means you already know that placing a patient in the prone position is something we do every single day. We do it in the operating theater for optimal surgical access, and we do it in the ICU to literally save the lives of patients with severe respiratory failure. But here's the thing. How often do we stop and truly unpack the profound and sometimes catastrophic physiological ripple effects that happen the exact second we turn a patient over? It is so much more than just a physical posture. It is an intense cardiovascular stress test. So today we're going entirely beyond the basics. We're going to break down the incredible cardiopulmonary shifts, the hidden hemodynamic traps, and the most advanced clinical strategies for optimizing the prone position. Let's dive right in.
Hello. I would like to express my gratitude for the dedication of surgeons, anesthesiologists, critical care specialists, and clinical researchers. Today, we will explore the prone position used in surgery and the intensive care unit. Buongiorno, vorrei esprimere la mia gratitudine per la dedizione di chirurghi, anestesisti, specialisti in terapia intensiva e ricercatori clinici. Oggi esamineremo la posizione prona utilizzata in chirurgia e in terapia intensiva.
Here is our roadmap for today's explainer. We'll start with a quick look at the evolution of prone positioning, then move deep into cardiopulmonary physiological shifts. From there, we'll cover frame risks and hemodynamic collapse, followed by advanced monitoring and venous return. Finally, we'll wrap up with optimization and complication prevention and our key clinical takeaways.
Section 1. Evolution of prone positioning.
Now, back in the 1930s and 40s, surgical teams didn't spend a whole lot of time worrying about abdominal compression when positioning patients face down. But as spinal, neurosurgical, rectal, and urological procedures advanced, pristine dorsal access became absolutely non-negotiable, and the engineering of our surgical frames evolved right alongside those needs. But here's the critical part. Our choice of frame dictates a massive cardiovascular response. Take convex saddle frames, for example, like the Wilson frame. Research by Yokoyama and colleagues way back in 1991 showed that these convex frames can dramatically drop a patient's cardiac index by up to 20%. Transesophageal echocardiography studies by Dharmavaram in 2006 further confirmed that these significant hemodynamic differences are tied directly to the positioning system used. Conversely, the Jackson table is often praised because it preserves baseline cardiac function much better. Why? Simply because its open structure allows the abdomen to hang freely, which significantly lowers intra-abdominal pressure compared to a convex frame. But, as we're going to explore very shortly, even the supposedly safest table has its own incredibly deadly traps.
Section 2. Cardiopulmonary physiological shifts. Let's look at the actual physiological storm that hits the moment a patient is turned prone. The very most striking, immediate shift we see is a sudden drop in both cardiac index and stroke volume. It's essentially a domino effect inside the body. The instant the patient is prone, their intra-abdominal pressure goes up. This elevated pressure physically compresses the inferior vena cava. When you squeeze the IVC, you immediately choke off venous return to the heart, which drastically slashes ventricular preload. And as we all know from basic Frank Starling mechanics, a lower preload absolutely guarantees a lower stroke volume. But here is where we encounter a very dangerous clinical illusion. The human body is smart, right? It rapidly ramps up systemic vascular resistance to compensate. So you might be staring at your monitor and the mean arterial pressure looks perfectly fine. It's holding steady. But that normal blood pressure is actively masking a severely compromised stroke volume, meaning your patient's end organ perfusion is secretly under threat.
This exact dynamic is brilliantly captured when we are managing patients with ARDS. A fantastic 2021 study by Lai and colleagues mapped this out perfectly. When you turn an ARDS patient prone, it naturally increases their mean systemic filling pressure. Now, the critical dividing line here is whether that specific patient is preload responsive. If they have preload reserve, that increased systemic pressure actually acts as a driving force. It powerfully pushes venous return forward, and the cardiac index will actually go up. But if they aren't responsive, the resistance simply mounts. The venous return resistance increases, and cardiac output either completely stagnates or begins to fall. So it's not a static situation. It is a constant, incredibly dynamic tug-of-war between venous resistance and driving pressure.
Section 3. Frame risks and hemodynamic collapse. Let's ground this physiology in a real-world scenario.
I want to walk you through a truly fascinating and terrifying medical mystery from the operating theater, documented by Park and colleagues in the Korean Journal of Anesthesiology. Imagine this. A 75-year-old, otherwise perfectly stable, obese female patient is being prepped for spinal surgery. She is carefully placed on a Jackson spinal table. Instantly, the moment she is prone, her blood pressure plummets to 45/35. Her arterial waveform completely flatlines into a devastating hemodynamic collapse. The team throws everything at her: massive fluid resuscitation, escalating doses of vasopressors, but she is entirely refractory. Nothing works. Now you really have to wonder, if the Jackson table is supposedly our safest option for preserving cardiac output by reducing abdominal pressure, why on earth did this patient experience such a catastrophic immediate failure? Well, the answer to that mystery lies entirely in gravity and anatomy. Think about a severely obese abdomen. When it's left completely unsupported on an open frame like the Jackson table, it hangs freely, sagging drastically down beneath the frame. Now here is the truly astonishing part of this case. The clinical team literally saved this patient's life by simply wedging a physical external support pad right underneath her hanging abdomen. The moment they stabilized that sagging tissue, her arterial waveform reappeared and her hemodynamics instantly stabilized. And if they removed the pad, the collapse came right back. So what exactly was happening inside her body that a simple pad could fix?
Usually, our biggest fear in the prone position is high abdominal pressure physically crushing the IVC flat. But in this case, the culprit was something slightly different: severe mechanical kinking and splanchnic blood pooling. Because her free-hanging abdomen had no support, its sheer weight pulled the viscera down so violently that it physically kinked the inferior vena cava. It's exactly like bending a garden hose in half. The flow just stops completely. Blood pooled massively in her splanchnic vessels, disastrously cutting off systemic venous return to her heart. So when the team placed that abdominal support pad, they weren't adding dangerous pressure. They were literally unkinking the hose. The pad pushed that trapped splanchnic blood right back into circulation. It's a stark, unforgettable reminder that a free-hanging abdomen isn't universally safe, especially for our obese patients.
Section 4. Advanced Monitoring and Venous Return. So how do we predict these collapses before they happen?
We all know that direct, invasive cardiac output monitoring isn't always feasible or justified for every single case. So what about a reliable, non-invasive surrogate marker? Recent prospective data from Wang and colleagues in 2025 revealed something truly ingenious. When a patient is turned prone, their abdominal organs inevitably push the diaphragm upwards, which increases intrathoracic pressure. On your anesthesia monitor, this translates directly into a rise in peak airway pressure. And crucially, Wang's team found that this airway pressure change has a remarkably strong negative correlation with the patient's cardiac output.
The predictive power of this simple metric is absolutely stunning. They found an area under the curve of 0.88. What does that mean for us in practice? It means that if you turn a patient prone and you see their airway pressure increase by just 4 centimeters of water, there is a phenomenally high probability that their cardiac output is going to plunge by over 25%. Literally, by simply watching the airway pressure numbers on the ventilator during the turn, we're given an incredibly sensitive, non-invasive, early warning system for impending hemodynamic collapse. It's a brilliant tool that belongs in every clinician's toolkit.
Section 5. Optimization and Complication Prevention. How do we proactively stop these issues?
With all these severe risks in mind, proactive optimization is absolutely key. When it comes to fluid management, a 2024 randomized controlled trial by Lee and colleagues gives us a brilliantly clear, actionable protocol. First, check the patient's baseline pleth variability index. If their PVi is over 16, they are fluid responsive. Second, administer a proactive 5 milliliter per kilogram intravenous fluid bolus immediately after induction of anesthesia. Finally, make absolutely sure you have perfectly stabilized their hemodynamics before you ever give the order to transition them to the prone position. Implementing this elegantly simple 3-step sequence dramatically slashes the incidence of pre-incision hypotension.
Now, bridging this over to the intensive care unit, we know prone positioning works absolute physiological miracles for ARDS patients. It's completely transformative. It increases functional residual capacity, clears out dorsal atelectasis, and vastly improves V/Q mismatch. A domestic study by Lim et al. Way back in 1997 even showed a 65% improvement in oxygenation among ARDS cases, noting that respiratory responders typically maintained a higher mean arterial pressure. Furthermore, work by Herring in 2001 demonstrated that as long as there is no rigid abdominal restriction, the prone position can actually improve cardiac index and maintain kidney function despite mild increases in abdominal pressure. This all leads us to the monumental pros of a trial highlighted in reviews by experts like Joswiak. We now know that prolonged prone sessions, over 16 hours, don't just improve oxygenation, they actively unload the right ventricle, maintain precious microcirculation, and ultimately drive the massive survival benefits we rely on today.
Section 6. Key clinical takeaways. Let's pull all this data together into actionable steps.
Despite its life-saving benefits in the ICU and its necessity in the OR, the prone position exacts a heavy toll if it is managed poorly. We are talking about severe, devastating perioperative complications. Things like postoperative visual loss, or POVL, driven by severe venous congestion in the head. We're looking at peripheral neuropathies from stretching the brachioplexus and profound localized pressure injuries. A comprehensive review by Edgecombe really hammered this home. Meticulous padding, strictly neutral neck positioning, guaranteeing absolutely zero direct pressure on the globes of the eyes, and constant micro-adjustments during long cases. These aren't just mere positioning guidelines. They are high-level preventative medicine that we cannot afford to skip.
So let's wrap up with our essential rapid-fire action items. Number 1, always stabilize hemodynamics before executing the turn. Number 2, be exceptionally cautious with your frame selection, particularly for obese patients or those with low cardiac reserve. Remember that hidden danger of IVC kinking we discussed with the Jackson table. Number 3, use airway pressure changes on your ventilator as a real-time, non-invasive alarm for dropping cardiac output. Number 4, proactively preload your fluid-responsive patients based on their PVi. And finally, number 5, in the ICU setting, aggressively leverage those prolonged prone sessions to secure profound ARDS survival benefits.
I'll leave you with this final, provocative thought. Is your institution routinely assessing preoperative cardiac reserve and fluid responsiveness before committing a patient to the prone position? Because as we've seen today, the prone position isn't just a physical posture, it is a profound cardiovascular stress test that demands our utmost clinical respect. Hopefully this explainer gives you the concrete tools and the deep physiological understanding to reevaluate and elevate your own institutional protocols. Thank you so much for joining me today, and I'll see you next time.